asked in the senior resident exam for Prostho, which was conducted last week. And I'll be giving you a brief outline about the topics which were stressed upon in that question paper, and the questions which can be asked regarding those topics, similar questions regarding to the similar data. So let's start with the lecture. So first question was that Rottweiler clasp is indicated in. So as you all know that Rottweiler clasp or a combination clasp. See, I have not uploaded the questions directly, but I have put the slides of the topic which have been asked in the question paper, because it will make things easier for you, because if I upload the direct question, first of all, the language gets tricky. So you should know the data or the theory near about the topic which has been asked. Secondly, then people, either some of you or some friends of yours will share this PowerPoint presentation, and those questions will be available to everyone out there, even the people who are not in Target Educare. So it's better that I just give you a brief outline, and so I'll be telling you the questions simultaneously with the topic which I am covering, so don't worry. So the first question is that the clasp which I indicated for Kennedy class 1 and class 2 partial denture. So as we all know that cast circumferential clasp is contraindicated in a Kennedy class 1 and Kennedy class 2 arch. So Rottweiler or a combination clasp which has a Rottweiler retentive arm and a cast reciprocal arm on the lingual side, that's called a combination clasp. So that is why Rottweiler clasp is indicated in class 1 and class 2 partial dentures, while a cast circumferential clasp is contraindicated in a class 1 and class 2 partial denture, Kennedy partial denture, in which the retentive undercut is on the mesiofacial side. See, now what are the advantages that when we see the Rottweiler clasp microscopically, we see the round cross section in the case of the cast circumferential, while in the Rottweiler clasp the planes are in one single line. That's why it can elongate in all directions. So it is easy to adjust. The Rottweiler clasp is easy to adjust. It is indicated in a Kennedy class 1 or class 2 when undercut is located at the mesofacial line angle. Advantages are that it can flex in all planes, it is adjustable, and it has a rigid reciprocal arm which compensates for any orthodontic force applied by the retentive arm. Okay, the second question which was asked was prosthodontic management of a patient with a Paget's disease. So suppose a patient reports to your clinic who is having a history of Paget's disease. So what is Paget's disease? Paget's disease is also called as osteitis deformans. So what happens in Paget's disease is that there is replacement of bone with highly vascularized low density bone. So this is a relative contraindication. Question is that suppose a patient comes to you with a history of Paget's disease. So and the patient is having multiple impacted teeth. So what will be your treatment plan? Whether you will extract all the teeth, make a complete denture, you will extract all the teeth, make a complete denture with a soft liner, extract all the teeth, place implants and make an implant supported overdenture, or extract all the teeth and make an implant supported fixed prosthesis. I'll repeat the question. A patient with Paget's disease having multiple impacted teeth reports to your dental clinic. There are 4 options. First option is that either you leave the teeth inside the alveolar bone and fabricate a conventional complete denture. Second option is that you leave the teeth inside the alveolar bone, fabricate a conventional complete denture and line it with a soft liner. Third option is that you have remove all the impacted teeth in the anterior region, place implants in the interforaminal region and then place implants and make an implant supported overdenture. And fourth option is implant supported fixed prosthesis. So the answer according to me should be a conventional denture with a soft liner, since multiple impacted teeth are there and if that will be having prominences on the soft tissue. So it will lead to frequent ulcerations if we give a conventional complete denture. So the better answer would be a conventional complete denture with a soft liner. See, let us now, there are a lot of questions about implants and related to osseointegration with the implants. So let's see the factors. Let's see the factors which are involved in osseointegration. So surface characteristics, that is the surface coatings, implant design, implant biocompatibility, state of the host bed, whether there is any inflammation or any infection in the tissues in which you are placing implants. See, I am telling you the questions, please listen to the lecture. This implant design is one of the factors affecting osseointegration, and 2-3 questions were asked regarding implant design. That's why I am giving you a basic idea about which are the factors involved in osseointegration. It's not necessary that the same question will be asked to you. Okay, so the second question is that what is pitch of an implant? Pitch is the distance between two threads. See, the distance between two threads is called the pitch. So lesser the pitch means more the number of threads, means there will be more surface area, so better osseointegration. So the question is asked, what is implant pitch? The answer would be distance between two implant threads. Cuspation and a small amount of lateral freedom for accommodation of Bennett movement on the horizontal plane is acceptable. Anterior guidance is determined functionally. During working movements, a harmony of contact on all inclines involved was necessary for both anterior and posterior teeth as determined by incisal guidance. In the balancing side, there should be no contact. Group function of canine guidance on the working side. During protrusive movements, an immediate disocclusion on the posterior teeth should occur. Factors that control the posterior teeth morphology are TMJ, incisal guidance, in which corresponding steepness would be a reflection of overjet and overbite, and Bennett movement. So, another difference between the Pankey man and the Hobos technique is that in the Pankey man technique, the anterior teeth are restored first, while in the Hobos technique, the posterior restorations are fabricated first. I have told you that the options were pretty long. The options for this question, these 2-3 questions cannot be reproduced. So next question is, an eyeball of the patient is removed while preserving the eyelids and other structures. So the answer over here is enucleation. The other option was evisceration, extenuation. The correct answer is enucleation, when the eyeball is removed but the eyelids, eyelashes and muscles are preserved. In evisceration, a part of cornea is preserved while the rest of eyeball is removed, while in enucleation the complete eyeball is removed. Another question was ideal cement for self-retained zirconia restoration. So I'll tell the difference again. Enucleation is when you remove the complete eyeball while preserving the eyelids, eyelashes and ocular muscles, while in evisceration a part of cornea or sclera is preserved while the rest of the eyeball is removed. So the answer over here is enucleation, since the question asked was that complete eyeball is removed while preserving the other structures. So answer is enucleation. Next question is ideal cement for self-retained zirconia restorations. Since zirconia is a strong material, it does not need strength from the tooth structure, unlike the Emax based or lithium disilicate based ceramics. So for lithium disilicate based ceramics, you need a bonded restoration. That is why resin cements are indicated. While for zirconia restoration, resin cement is not a must. Since the question mentions self-retained, so according to me the answer should be a glass ionomer cement. So the ideal cement for self-retained zirconia restorations would be a glass ionomer cement, since the resin cement does not have any added advantage, and the question mentions self-retained, so we don't need excessive retention. That is why the correct answer would be a glass ionomer cement. Another question about the soft palate resection. So if the patient has a tumor in the hard palate and some part of soft palate is also removed, so if 1/3 of soft palate is remaining, you should always advise the surgeon to remove the complete soft palate, because it creates difficulty in fabrication of speech prosthesis or a soft palate obturator. So whenever during resection it is found that less than 1/3 of soft palate is remaining after surgical resection of the tumor with clean margins, the surgeon should always be advised to resect the complete palate if less than 1/3 of soft palate is remaining after the surgery. So options here were if half is remaining or 1/3 should be left intact. So the correct answer is that if less than 1/3 is remaining, everything should be removed. So next question was on Aramany classification. Class 1 is midline resection. So the question asked was on midline resection, which is a class 1. It is classified into 6 types. You can see in the diagram. Class 1 is a midline resection. Class 2 is unilateral resection. Class 3 is central resection. Class 4 is bilateral anterior resection. And class 5 is posterior resection. And class 6 is anterior resection. So the question asked here was midline resection, which is a class 1. Next question is, which undercut should be utilized for a maxillary obturator? The superolateral undercut should be utilized for a maxillary obturator always, because on the medial side respiratory mucosa is there, and whenever grafting is also done, it creates an undercut on the superolateral side of the defect. So superolateral undercut should be utilized for maxillary obturator. Now, next question, you might find it boring, but at least 2 to 3 questions were asked out of this table. Again, exact questions cannot be reproduced because the options were quite long. So please learn this table properly. It shows vertical and the horizontal determinants of occlusion. So the vertical determinants of occlusion are condylar guidance, anterior guidance, plane of occlusion, curve of P, and lateral compensating curves. while the horizontal determinants of occlusion morphology are distance from the rotating condyle, distance from the mid-sagittal plane, lateral translation movement, and intercondylar distance. So one of the questions was that steep condylar guidance would call for, answer would be taller posterior cusp. Then anterior guidance, if there is greater anterior vertical overlap, there will be steeper anterior guidance, which will also again call for taller posterior cusp. So one of the questions asked over here was, even though the anterior guidance being 0, please listen the question. Listen to this question. Even though the anterior guidance being 0, still posterior disocclusion can be explained by all of the following except. Even though the anterior guidance being 0, all the following can be explained as a reason for posterior disocclusion except. So the answer over there would be intercondylar distance, since that is a horizontal determinant of occlusion and not a vertical determinant of occlusion. Another question which was asked about cast partial denture was movement of a cast partial denture in a horizontal plane occurs around which axis? Movement of a cast partial denture in a horizontal plane occurs around which axis? The answer over here would be vertical axis. In the horizontal plane, the movement would be around vertical axis. Okay, that's I'm done with the question. So now if you have any doubts, you can ask me your doubts or queries. I am done with the questions. Please ask your doubts.